If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we'll go through the recommendations by the European Association of Urology, or EAU, on male hypogonadism, focusing on what is relevant in primary care only. The link to the guideline is in the episode description. In today's episode, we'll cover the definition, classification, causes and clinical associations of male hypogonadism. In the next episode, we'll focus on the clinical presentation, interpretation of test results, and a brief overview of the management. Right, let's jump into it. Male hypogonadism is a clinical condition characterized by symptoms with or without physical signs and confirmed by low testosterone levels. Hypogonadism is linked to reduced testicular function, leading to decreased production of androgens such as testosterone and/or impaired sperm production. This may result from a primary problem within the testicles, that is, primary hypogonadism, or from insufficient stimulation by the hypothalamic pituitary axis, or secondary hypogonadism. In rare cases, it may be due to reduced cellular response to testosterone. Hypogonadism can negatively affect various organ systems and overall quality of life. This episode focuses on the management of adult male hypogonadism, also known as late-onset hypogonadism, although it may include some comments on congenital or prepubertal forms of the condition. The prevalence of late-onset hypogonadism increases with age, with the major causes being obesity, other comorbidities, for example diabetes, and overall poor health. Aging accounts for a low percentage of hypogonadism, as there's only a small gradual decline in testosterone up to the age of 80 years in healthy aging men. There is a high prevalence of late-onset hypogonadism within specific populations, including patients with obesity, type 2 diabetes, metabolic syndrome, cardiovascular disease, COPD, renal disease, and cancer. In particular, low testosterone levels are relatively common in men with type 2 diabetes and in those with metabolic abnormalities. Klinefelter syndrome, a trisomy associated with the 47XXY karyotype, is the most prevalent genetic cause of primary hypogonadism, with a global prevalence of 1 every 5 to 1,000 live male births. However, less than 50% of individuals with Klinefelter syndrome are diagnosed during their lifetime. Male hypogonadism can be classified according to the cause into primary hypogonadism or secondary hypogonadism. A compensated or subclinical form of hypogonadism characterized by normal testosterone and a high LH has also been reported, but the clinical significance of this condition is unclear. The classification of hypogonadism has also been divided into two broad categories: classical or organic and functional. Classical hypogonadism includes congenital or acquired diseases causing structural and/or irreversible impairment of the pituitary gland or testicles. Functional hypogonadism is diagnosed in the absence of any recognized organic abnormality, and it is mainly a consequence of comorbidities. It should be treated first by improving the underlying condition, for example, anorexia in a younger male. Late-onset hypogonadism represents an even broader clinical entity, including adult-onset forms, which can have an organic or functional origin and can be primary or secondary. Late-onset hypogonadism is in the majority of cases diagnosed in the absence of an identifiable organic cause. By definition, late-onset hypogonadism must comprise both persistent specific symptoms and biochemical evidence of testosterone deficiency. Finally, as we said earlier, in rare cases, it may be due to reduced cellular response to testosterone. The European Association of Urology guideline maintains a classification of primary and secondary hypogonadism, with special reference to late-onset hypogonadism. Classifying hypogonadism by its underlying cause will also help guide treatment options. For example, in secondary hypogonadism, Both fertility and testosterone levels can potentially be restored with proper therapy. In contrast, primary hypogonadism usually requires testosterone replacement, which can impair fertility by suppressing the hypothalamic pituitary testicular axis. We need to remember that when hypogonadism develops after puberty, especially as men age, its symptoms may be mild and often mistaken for normal aging. Let's now look at some common causes for the three main categories of male hypogonadism. Please note that the list is not exhaustive. In primary hypogonadism, we can have congenital and acquired causes. Common congenital causes of primary hypogonadism include Klinefelter syndrome, the most common, other chromosomal disorders like Down syndrome, and also conditions like sickle cell disease, amongst others. Acquired causes of primary hypogonadism include drug-related, like for example in chemotherapy drugs, direct testicular damage, like for example bilateral orchidectomy or bilateral testicular trauma, radiation to the testes, and infective or autoimmune urchitis. And finally, systemic diseases that affect the testes, like for example Cushing's syndrome, HIV, and cancers like lymphoma or testicular cancer. In secondary hypogonadism, we also have congenital and acquired causes. Congenital causes of secondary hypogonadism include hemochromatosis and other genetic or idiopathic causes. Acquired causes of secondary hypogonadism include drugs that suppress the hypothalamus or pituitary gland, like for example estrogens and progestogens, testosterone or anabolic steroids, drugs that increase prolactin, opiates, and corticosteroids. Local problems in the brain, like for example head trauma, tumors in the pituitary gland or hypothalamus, surgery or radiation to the pituitary gland, and infections or inflammation in the brain. And finally, systemic conditions that affect brain hormone control, such as for example type 2 diabetes, metabolic syndrome, chronic organ failure, HIV, rheumatoid arthritis and other chronic inflammatory diseases, Cushing's syndrome, and eating disorders. I will only touch briefly on the androgen resistance or reduced testosterone activity type, where testosterone levels may be normal, but the body can't respond properly to it. Causes include genetic conditions affecting androgen receptors, drugs that interfere with testosterone function, high levels of sex hormone binding globulin, which reduces free testosterone, and conditions like celiac disease, which can also interfere with hormone action. Let's now look in more detail into comorbidities associated with male hypogonadism. And the first one is obesity. Low testosterone levels are common in obese men. Male hypogonadism is associated with a greater percentage of fat mass, and low testosterone levels are strongly associated with increased visceral adiposity, lipid deposition in the liver and muscles, and atherosclerosis. The second one is metabolic syndrome and type 2 diabetes. Given that male hypogonadism is commonly associated with metabolic syndrome and its individual components, including central obesity, hyperglycemia, insulin resistance, dyslipidemia, and hypertension. Additionally, several randomized controlled trials have shown that testosterone therapy can improve insulin resistance, reduce blood glucose levels, lower total cholesterol, and lower LDL cholesterol. Some studies suggest that testosterone therapy in men with metabolic syndrome and low testosterone may be associated with reduced mortality compared to those who are untreated, although the results are not conclusive. Erectile dysfunction is very common in men with metabolic syndrome and type 2 diabetes. Additionally, although erectile dysfunction is multifactorial, up to 30% of men with erectile dysfunction also have testosterone deficiency. This means that men presenting with erectile dysfunction should be screened for metabolic syndrome and diabetes, but also that those with erectile dysfunction should also have their testosterone levels measured to screen for possible hypogonadism, especially if they have diabetes or metabolic syndrome. I will also just mention that data suggests that low testosterone levels are more frequently associated with worse clinical outcomes in men with COVID-19, although the link and the exact implications are still under investigation. So that is it, a review of the definition, causes and clinical associations of male hypogonadism. Remember that in the next episode I will cover late onset hypogonadism in more detail, including the clinical presentation, laboratory testing and its interpretation, and a brief overview of the general management. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.